This is It's Not In Your Head podcast with Dan and Juz. Dan is a doctor and Justine a pain coach. We've come together to find ways to manage complex chronic pain better for both patients and providers. Hey there, welcome to another episode of It's Not In Your Head podcast. I'm your co-host, Justine Feitelson, here with Dr. Dan Bates. Hey, Dan.
Hey, Juz. It's like got finished? Straight into it. Like
I know.
I am like talking about how...
Well, we were just talking about how you just...
Because got punched in the head by everyone at boxing, yeah. Anyway.
Yeah, well, it's better than when you showed up with a little raspberry. Kind of remember that?
Sure.
Right there?
Sure.
Yeah. All right. Well, we're going to keep procedures rolling today. So if you've listened to some of our more recent shorties, we started doing a long series of these, and that's what we're going to carry on with today. And today we're going to cover epidurals in specifics, which are a broad term and can be done all over the body with different materials. So Dan's going to dive deep into what he uses them for, how do they actually work, what does the procedure itself and the recovery look like. So to begin with, Dan, how would you explain what epidurals are?
Okay, so epidurals are where you're doing an injection into the epidural space. So what does epidural mean? So your spinal cord, your spinal cord sits in a sac. Okay, that sac is called the dura. Epi means outside the dura. So that's pretty much what you're doing. There's a little space that sits between the vertebra in which the spinal cord is sitting, the dura, and then you get bone, and that's the epidural space, and that's where we're putting in either local anesthetic or cortisone or a range of other things. And so epidurals can be done in multiple different ways. So there's a thing called an interlaminar epidural. So for those listening that have had epidurals during pregnancy, that is what they do. So they do what's called an interlaminar epidural. And in that setting, they're just putting local anesthetic into the epidural space, and it helps decrease, the pain of labor. There's then a couple of other epidurals, one called a transforaminal epidural. So where all the nerves come out of the spine is called a foramen. When you're going through the foramen, it's called transforaminal. There you go. It's not very exciting, but that's how we name it. And so you can do them up at the cervical spine. You can do them, which is your neck. You can do them at the thoracic spine, which is sort of obviously chest, and then lower back. And you can also do it down over your sacrum as well. What you're doing there is you're specifically targeting the nerve root. It allows for a more targeted diagnostic type procedure. The third type is called a caudal epidural. That targets the very bottom part of the spine, and it's kind of like washing over the whole, like you're trying to capture as many as the nerves down the bottom of your spine as you possibly can, and you're just trying to calm everything down.
So you're trying to cast the widest net with that version?
Yeah. And you're essentially doing the same with an interlaminar. An interlaminar epidural, What happens with that, it sits, you can imagine you're coming from the back of the spine. And so when you're putting the injectate in, so the local or cortisone or whatever, it sits at the back part of the spinal canal. Okay. And in that setting, you are then washing across the back part. With something like a transforaminal, what you're doing is you're getting to the front part of the spinal canal, which is at times more useful because the way that your body's set up, you've got your discs at the front. If you've got a disc that's sitting at the front and it's bulging backwards, you want to be getting your local and cortisone where the bulge is, not on the other side at the back. And so that's different reasons for why you may, why you put it into different spots. Yeah. And you can do fancy stuff. You can go above the nerve, you can go below the nerve, you can go behind the nerve. You can position in the needle based on, okay, I think I've got compression at this point because of a disc, or maybe you've got, a big facet joint that's pushing on the nerve, and so that'll be pushing from behind. So you might do an injection that is called retroneural, so behind the nerve, to see if you can get it at that level. Now, in real terms, how much difference does it actually make? We don't know, because no one's really done a ton of data on what happens if you put it here, there, or here.
Specific needle for specific diagnosis.
Yeah.
And it's probably a bit of a combination of what methods do you grow to become more comfortable and use more frequently, alongside what do you think the driver, the cause is, because you're not
Yes.
going to do
Yeah.
them all equally. Yeah.
Yep.
Frequency wise.
So it makes sense. And so like for us and most of the guys I work with, we will be using transforaminal epidurals for diagnostic things. So if I think this is an L5 nerve root that's getting pushed on, I will be doing a transforaminal epidural at L5 to try and confirm that that's what the problem is. Other groups will do, if they think it's, a nerve root compression, they might just do an L3-4 interlaminar epidural, which covers everything.
Okay.
And you might get a decrease in pain, but it's just not as diagnostically valuable.
Right. And that's the split then is it just intention based? Am I using this from a diagnostic perspective, or am I using whatever I can to just give me the best shot at covering the pain, and on we go? And
exactly. And you know what? There's times when the patient comes in and everything's out of control.
Right.
You can't actually, you're like, I can't pick where this is coming from. We've just got to calm this down. Boom. That's where you're going to do an interlaminar, or you're going to do a caudal epidural of that node. And so you get broad coverage over a wide area. And that calms the intensity of the pain down, hopefully then becomes more focal, and you're like, okay, where is it now? And then you might be able to pick what the structure is.
That's helpful.
Yeah. So next one. Come on, give me another question.
Next one. All right. Is there anything else along what types are there? Would you go with what you're literally injecting?
So is there other injectables? Okay, so the main injectables are a local anesthetic. So those local anesthetics will be either xylocaine or lignocaine, lidocaine if you're in the US. You can use other long-acting local anesthetics like ropivacaine or bupivacaine, or marcaine is the other one. I tend to avoid those because they are long-acting.
What's the downside with the long-acting?
Well, if it goes pear-shaped, then it lasts for a long time.
Pear-shaped situation. That's a good answer.
That's the upshot. And so long-acting is effectively, between 2 and 24 hours. There's also in the olden days, like this is 1960s type period, they used to use marcaine for epidurals. So marcaine is also known as bupivacaine. The downside now, and they would inject 20 mils. Okay, so 20 mils. This is a big injection. I haven't put 20 mils
of lot of fluid
into an epidural space. The downside of marcaine, if you get it into a blood vessel, is intractable VT, which is ventricular tachycardia, or intractable VF with intractable, which is ventricular fibrillation, which unfortunately means the patient dies. And so guess what?
Upon. That's a big pear-shaped.
That is breaking rule number one.
The number one rule of medicine. That's exactly what I was thinking.
Rule number one.
What's the number one rule?
Don't kill the patient.
Don't.
Okay. I logically don't use marcaine in patients. I don't use it in epidurals for long. I don't use large amounts, and I don't use little amounts. Stick to xylocaine. But you can use different local anesthetics. Other injectables include various types of cortisone. So now this is
downside of cortisone. Little caveat.
Yeah. Okay. So let's go with there's two main types if we're going to split them. First one is aqueous types of cortisone. So this effectively is dexamethasone. Okay, and so pretty much it's watery. Okay. There's other types of cortisone that have got crystals in it. All right. And so this is where you get your problems. If you have a complication and you inject the cortisone into something like an artery
with a liquid,
and you've got a whole stack of crystals into it, that is when you then get your big problems with if you're up in the cervical spine, stroke, and if you're in the lumbar spine,
like blockage,
paraplegia. Yeah, because you are injecting an artery that then goes on to supply a neural tissue. That neural tissue gets blocked off, and that's when you get your strokes and spinal cord injury. Now, what's the rule? Well, rule number one, don't kill the patient. So don't use particulate cortisones. So I don't use particulate cortisones in epidurals. So that includes celestone and cortisone and Kinacort and all those other ones that are particulate. I only use dexamethasone, and I only now use dexamethasone in everything. So that there's no confusion from the staff of
what gets it and what doesn't.
He uses celestone for this procedure and dexamethasone, not just dex
Keep it the same.
No problems with it. And then you've got no risk of hurting anybody. And so
why would anybody use the crystal bleed?
Okay, so
cost?
No. Cost. Well, interestingly, if you're doing celestone into stuff like joints, it probably works a bit better than dexamethasone. Okay, and so back in the day, there was some data that suggested that celestone was more effective as an anti-inflammatory than dexamethasone, and I think that data was probably propagated out across multiple injections rather than having hang on, does that make so much sense here?
Right. In what situation does it make sense rather than this is kind of standard and then we change the standard?
So sure, dexamethasone is probably a little less effective if you're doing, a joint type injection, but I think that I want to minimize my risk of complications, and so I don't want staff getting confused by different types of cortisone, so I just don't use it.
Especially the super pear-shaped complications.
You don't want that. So, okay, so we're talking about the complication stuff here, so let's sort of finish that off. So any injection, there's risk of infection. There's a risk you get some bleeding. There's a risk you get some bruising afterwards. So infections include skin infections, muscle infections, and then deep infections. So in that setting, a deep infection is an epidural abscess. Epidural abscess is bad. So that is the bad infection. They are very, very rare, but they are possible. The risk of infection based on the intra-articular data is probably 1 in 15,000. I would say it's, for what we've seen, it's much, much lower than that. So, but that's the big one. When you're talking about bleeding, you may get a bruise. But the other big risk is if you have an epidural bleed. So that's called an epidural hematoma. And what you got there is you've got a collection of blood and the risk becomes spinal cord compression. If that's the case, there's some techniques actually to get people moving and it actually moves the blood out of the space, but it could result in needing a decompression. Once again, super rare. Very rare. Haven't seen one before. I don't know it, and I don't actually know of any colleagues that have had any. So it's a very rare complication, but it does take place and has been reported. The keys there are ticking off on people's anticoagulants. So, if you're going to go forward with an epidural, we're basically going to be wanting to cease people's anticoagulants. So that's Eliquis, Xarelto, aspirins, clopidogrel, warfarin, Coumadin, those sort of things. That'll be where your doctor will likely be reaching out to who is the blood thinner question. Yeah, who is the prescriber of this, and can we please stop it? And so that'll be that's pretty much how you handle that situation. Most blood thinners are safe to cease for a period of time. However, there's a couple of very specific limitations that I think everybody needs to be aware of. If you've had a stent, like a cardiac stent, it is very important that you do not stop I'm not 100% where it's at. I ask everybody at any rate, but it's certainly within 6 months, probably 12 months. And I will be asking your cardiologist whether it's okay to stop. If you've had a stent, definitely within the last 6 months, do not stop your anticoagulants. That is we need to find another solution to it.
Sooner, more recently your stent has been put in, the more significant
don't stop there. Well, because the issue is that you run the risk of it clots off, and when a stent clots off, that's bad. I've seen that when I was doing cardiology as a baby doctor, and it's pretty ugly. So don't do that to yourself.
Yeah, don't do that.
The other major, interestingly, anticoagulant that we see that's not prescribed is fish oil. So fish oil makes people really leaky. It's quite interesting how much of an anticoagulant it is. So if you are on fish oil, make sure that you tell your doctor and make sure that you cease that as well.
That's an interesting one. Yeah, I never had fish oil last. So that's the nugget. All right, that's the sneaky nugget in this episode.
That's the one. So that does make you leak really well.
Very interesting.
So that's why we want to avoid those complications.
And a lot of us are supplementing with that specifically.
Tons of people
that's
are.
And you should be actually. In a lot of cases,
No. Fish oil's got some great data, but
before.
You want to be stopping it pre-procedure because you do leak. It's an interesting type of bleed too. It's sort of very annoying to stop. So okay. So there's 2 other complications that you need to be aware of. We'll go through. Firstly, obviously when you're putting in a needle and you're putting it near a nerve, there's the risk that you actually hit the nerve. Now, if people hit the nerve, what happens is that, it hurts and people get like a
More
shooting
pain,
thing
not
down
less.
their leg.
Yeah.
The good news is it stops. Okay. And so like that pain does not continue after. It hurts at the time, but it goes away and it's not a continuous pain afterwards. The other things you can get in that setting is that each one of these nerves that we are ejecting around sits in a sac, as I said before, that's called the dura. If you put a hole in the dura, that's called a dural puncture. It can leak and then give you a headache.
Yeah.
So that's a CSF leak. What will generally take place is it'll go away. It just goes away over a couple of days. If it doesn't go away, the treatment for that is an epidural blood patch. Now, to put that into context, I've never had to do that for this type of procedure. Rarely have I seen an epidural puncture with this, but for those ones that you see, I've never had to do an epidural blood patch, but that is the treatment for it. The other thing that you can get is if you get local anesthetic inside the sac, that is called a spinal block, okay? And so what happens there is that the local anesthetic doesn't just spread around like the nerves. So let's say it's around L5 and you get a weak big toe. It spreads then across all your nerves and none of your legs, and your legs don't work. And so people come out and like,
too good of a result. Too good.
My legs don't move. And it's very different. It's very
less
different
pain.
to...
Legs don't move.
Yeah. So it's very different to, I've had an epidural, my leg feels a bit weak. That's normal. It is you come out and you can't move your legs, and it lasts for the period of time the local anesthetic lasts for, thus the short-acting local anesthetic.
That's the tie-in.
Which is going to be 2 to 4 hours. And then it's quite interesting how it behaves. It then just disappears all of a sudden, like it just wears off. And wears off really quickly, and then you walk home, and it's all fine. Yeah, and it's just it's an anxious 2 to 4 hours. So
it's short actings.
Interestingly, so the way you avoid those things is you do your epidurals with contrast. And so whenever I'm doing an epidural, whether it be in a CT scanner or whether it be in theatre, I'm using contrast. You inject the contrast first. You want to see where it flows. You're looking for specific flow patterns that mean I'm not in, number one, a blood vessel, and because you don't want any complications. And number two, like if it's in a blood vessel and then you inject a bunch of local and cortisone, it just goes somewhere else.
So you use the dye to see, to see where. So
you're using the dye to show you're not in a blood vessel, so you don't get a negative block, and you use a dye to show that you're in the epidural space. You're not within the dura, which is called intrathecal. And so if you do those things and you watch where your dye goes and you pay attention, then you don't get a spinal block. And so it's been a very long time since I've had a spinal block. I think, 5-6 years since I've had one. So I don't think I can remember 2 in my career. So
standard safeguards.
Yeah. So don't be stupid, do the job properly, and things generally go pretty well. So there are your complication rates. I think, what do we use it for is probably the next question.
Yeah, what are you treating from either a diagnostic or pain relief perspective?
The main treatment you're looking at treating nerve root compression. This is kind of interesting. We'll get into technical detail here. So people in the lower limb will call that sciatica. Now, sciatica, if you particularly speak within a Australian context, is like, it is a very specific, and I'm going to say rare presentation. It is a bolt of lightning that goes down the back of your leg. It is the easiest diagnostic thing in the world to pick. If it's going down L5, it goes to your big toe. Going down S1, it goes to your little toe. It's going down L4, it goes to your shin. It's going down L3, it goes to your inside part of your neck. It is the easy. It's a bolt of lightning. It's terrible. And you know what? It's generally very responsive to an epidural, depending on, how much nerve recompression you've got. But most people say, I've got sciatica when they've got leg pain. Well, like facet joints give you leg pain, sacral joints give you the
nerve pain that goes a little bit more south.
So, but what we're doing is, in this setting, you're treating radiculopathy. So radiculopathy is where you've got nerve recompression. You'll have pain in the distribution of the nerve, which is called a dermatome, and you'll probably have weakness, pins and needles, numbness, sort of in a similar distribution. So what that nerve is supplying will be dysfunctional. So it'll be pins and needles and numbness, or it'll be weakness. And you're doing a targeted injection around that nerve root. And so you can do that actually in your lumbar spine, your sacral spine, your thoracic spine. So thoracic spine,
same thing at every level,
that's wrapping around your chest, and cervical spine will give you with nerve root compression. Interestingly, what they do is that gives you pain between your shoulder blades and then down your arm. Okay, and so C5 goes to your elbow, C6 to your thumb, C7 to your middle finger, C8 to your little finger and ring finger, and T1 goes to the inside part of your elbow.
And this kind of reminds me of, you can, if you're listening to this and you're kind of thinking back on your pain presentation, go listen to our Draw Your Pain episode, because that also has a lot of these nerve, pattern pathologies that you can match up to. Oh yeah, just like Dan's saying, that's why I have shooting pain. That's why I have pins and needles. And it can make sense of an otherwise kind of confusing and hard to diagnose thing that shouldn't be that hard if you can pinpoint the right spot. Yeah.
So that's radiculopathy, which is essentially nerve root compression taking place at those levels. The other reason we'll use them is post-procedure. So there's a lot of data around using things like caudal epidurals, where you're washing over a whole stack of nerves to try and calm down the nervous system after you've done a procedure. And there's generally pretty good data across the board with epidurals of some sort, interlaminar or caudals or whatever, to decrease pain post-procedure. So we do that a lot, particularly when I'm doing radiofrequency neurotomy. Right. And I also use them as a means of trying to settle down pain sensitization. In this setting, when we're talking about sensitization, you'll get peripheral sensitization, which is the nerves at the site. So let's say you've got a knee that is wound up, or you've got a hip. Hips are a great example of this, actually. So you get hip osteoarthritis, you get the femoral and obturator nerves supply the hip, and what ends up there is they get bathed in a whole stack of inflammatory goop because of the arthritis in the hip. They get super hypersensitive, so you treat those. But that hypersensitivity of the nerves, that persistent pain signal, then winds up the dorsal root ganglion, which is where all the cell bodies for the nerve exist, and that sits in the foramen just before it enters into the spinal canal. Yeah. And so you can down regulate how that wind up that's taking place in the central nervous system by targeting the DRG or the dorsal root ganglion. So I use that in a process where we're trying to decrease peripheral and as much central sensitization that I can get from an interventional perspective. All your other mechanisms, dealing with your anxiety, dealing with your depression, dealing with your external metabolic stresses, will help deal with the other central sensitization drivers. But this is a interventional means by which you can actually get at that.
Yeah. So you can use it.
Other reason why you might use some epidurals.
It's cool. So diagnostically with regards to sensitization in general, and then also as a just total pain output post-procedure pain management strategy.
Yep. So pain minimization, and then central sensitization, or at least a component of it, and then those specific pathologies that you're looking at. So you're looking at nerve root compression.
Circling back to the radiculopathy example with nerve root compression, how do you extend it out, Dan?
Ooh, so that's interesting. So the way you extend it out, so there's some data around the use of what's called pulsed radiofrequency. So radiofrequency is a technique where you create an electrical field around the nerve, and it triggers off gene translation, and you get the upregulation of the release of anti-inflammatories and downregulation of pro-inflammatory factors. It's very important here to discern between thermal radiofrequency. So that's where you ablate a nerve. And that was when we're treating things like osteoarthritis, and we're treating a little branch of a nerve that you are then burning at 90 degrees. Pulsed radiofrequency is done at 42 degrees. So it's kind of like a warm bath. Yep. It's pulsing the nerve in little bursts. It's anywhere between 2 and 10 times per second. And within each one of those bursts, it's going at 500,000 times per second. And it's triggering off gene translation. It's really interesting the way it behaves. And so what you generally see with this is you'll see the patient on the day will get if you're in the right spot, patient gets a decrease because of the local anesthetic. It then tracks back up a little bit over the next couple of days, and you'll have a cortisone effect that will last for your 4 or 6 days. And then it'll either stay stable or track back up until about day 12. And at about day 12, it drops off. And so, and it's fascinating how reliable that pattern is across so many patients. Now, that drop-off might take place as late as 35 days. We do see that as well. But it will then last for 3 to 6 months. And so I like it. It's a really good technique. You can repeat it. I think that what we are seeing in our data at the moment is that if you repeated it about that 4-week mark for that group of patients that, have not got as much as they would want, you can actually get some improvement. I think that if you leave it so that let's say they started at 8 and then you leave it 3 months because they're good and they're back at 8 again, they do respond, but they only come back down to their 4s. I wonder at the moment whether what we're seeing is that, you go from 8 to 4 and you treat it again, you go from 4 to 2, but we're just pulling that data.
Hit it harder earlier. Yeah, and for more on these, check out the episodes that we did on radiofrequency neurotomy and radiofrequency ablation, because I think this was in those two to a degree. Okay.
All right. So that's the majority of epidurals.
There's nothing else, recovery, day of procedure that comes to mind, Dan?
Look, I think that everybody just needs to take it easy.
Touched on them, but yeah.
Like, for my athletes, okay, take it easy.
Hey.
Like, don't run home. Like that's the key.
Don't pick on
so it's not a Dan, what can I do? Can I go for a run? And they mean, hey, can I run home?
Can I run?
It's so take it easy. You want the cortisone or whatever therapeutic thing you're trying to get to work to have its effects. You want to give it 3 to 10 days to actually try and kick in. However, for my normal everyday human beings,
regular people,
go about your normal life as you feel comfortable.
Right. It's not like this, oh my God, I'm so restricted. It's just don't push yourself more.
It's not the time to start running marathons, but it's also, but don't go do nothing for, the doctor said do nothing for 4 days. Well, no, don't do that.
Lay on the couch
just
for 3
go
days.
in. Don't do that. Just get around, walk around normally. Don't decide it's the time to start running marathons. Live your life as you would be normally. No. Then we'll start getting you towards running.
Yeah, recover and then move forward. Exactly. Yeah. Plus, by then you're feeling better. So that's the goal.
Athletes, take a chill pill.
I feel offended by that. I don't know what you mean. True. That's like a week spinal cord stimulator surgery. I was like, God, I think I did too much. Anyway, that's all it was. All right. Anything else? Epidural rise. No. I think that was a good.
No, that's plenty of time. That's plenty of
epidural talk. All right. That's good though, because there's a lot of different ways you can use them, a lot of different parts of the body. So regardless of what your pain drivers are, I hope you enjoyed. Thanks, Dan, for your expertise. Yep. And we will see you next time on another procedural episode of It's Not in Your Head podcast.
Thanks, Jess. See ya.
Thank you.
Thanks for listening. Clearly, this is a podcast. It's for informational purposes. It's not a consult, medical advice, or the practice of medicine, and it doesn't form a therapeutic relationship. If you feel the information might be useful for your situation, before applying it to yourself or others, you should speak with your doctor or your treating clinician. Do not delay in seeking a diagnosis or treatment, and applying the information is at the listener's own risk.